This is Unit 3, Diabetes Topics. This presentation is going to be about cardiovascular disease. It is a long-term complication of diabetes. Cardiovascular disease is an umbrella term. It covers all types of diseases of the blood vessels and heart. Sometimes the terms cardiovascular disease, heart disease, and coronary heart disease are used interchangeably. We want to ask ourselves, what can CVD lead to? It can lead to heart attacks, strokes, and peripheral arterial disease. So, how does diabetes affect cardiovascular health? Typically, people with diabetes have poor control over their blood glucose. High blood sugar can cause damage to blood vessels and nerves. Diabetes is a huge risk factor for cardiovascular disease because many risk factors of diabetes mirror those of CVD. I have a few videos here to show you. The first one is short and sweet, and the second one's a little longer, but it has really good introduction information on the pathophysiology of cardiovascular disease.
Take diabetes to heart. Linking diabetes and cardiovascular disease. Meet Michelle. Michelle enjoys spending time with her family, and in her spare time, she loves to cook and catch up on her favorite shows. She also has diabetes. And like many people with diabetes, she doesn't know there's a link between diabetes and cardiovascular disease. Cardiovascular disease includes conditions such as heart disease and stroke. If you have diabetes, you're more likely to have risk factors associated with heart disease, including obesity, high blood pressure, or high cholesterol. These put you at risk for heart disease and stroke. Over time, high blood glucose from diabetes can damage your blood vessels and the nerves that control your heart. And adults with diabetes are nearly twice as likely to die from heart disease or stroke as people without diabetes. But there's good news for Michelle. She can take steps today to reduce her risk, and so can you. Here's what you can do to protect your heart. Manage your diabetes ABCs: A1C, blood pressure, and cholesterol levels. Ask your healthcare team what your goals should be. Develop or maintain healthy lifestyle habits and learn ways to manage stress. Take medicines as prescribed by your doctor. Stop smoking or using other tobacco products. With lifestyle changes and a treatment plan from her healthcare team, Michelle can look forward to living a healthy life, and someone's very happy about that. So take diabetes to heart. Visit niddk.nih.gov for more information on the link between diabetes and cardiovascular disease.
This is Tom from ZeroToFinals.com. In this video, I'm going to be going through cardiovascular disease. You can find written notes on this topic at ZeroToFinals.com/CVD or in the cardiology section of the Zero to Finals medicine book. Let's jump straight in. So first let's talk about atherosclerosis. Athero basically means soft or porridge-like. Sclerosis is hardening. And atherosclerosis is really a combination of atheromas, which are fatty deposits in the artery wall, and sclerosis, which is the process of hardening or stiffening of the blood vessel wall. Atherosclerosis affects the medium and large arteries in the body, and it's caused by chronic inflammation and activation of the immune system in the artery wall. So this causes deposits of lipids in the artery wall, followed by the development of fibrous atheromatous plaques. These plaques cause a few different problems. Firstly, they cause stiffening of the artery wall, which leads to hypertension or raised blood pressure. This is caused by the strain on the heart trying to pump blood against an artery wall that won't expand with the extra pressure. So it pumps against that extra resistance and causes higher blood pressure. The second problem is stenosis. So this is a narrowing, because of the plaques, of the space that the blood can flow through in the blood vessel. And this causes reduced blood flow in conditions like angina or peripheral vascular disease. And the third problem is plaque rupture, and this is where the plaque breaks off and gives off something called a thrombus that travels down the vessel and blocks a distal part of that blood vessel, leading to ischemia. And this is the main cause of acute coronary syndrome or heart attacks. So what are the risk factors for developing atherosclerosis? It's quite important to break down these risk factors into modifiable and non-modifiable risk factors. There's nothing we can do about the non-modifiable risk factors, but we can do something about the modifiable ones. So the non-modifiable risk factors are stuff like older age, family history, and being male. And the modifiable risk factors are smoking, alcohol consumption, poor diet, things like eating high sugar or trans fat diets and not eating enough fruits, vegetables and omega-3s, low exercise, obesity, poor sleep and stress. There's certain medical comorbidities that really increase the risk of atherosclerosis, and these should be carefully managed to minimize the risk. And this is stuff like diabetes, type 1 and type 2, hypertension, chronic kidney disease, and then inflammatory conditions such as rheumatoid arthritis, because remember atherosclerosis is an inflammatory process, and atypical antipsychotics that might be used in schizophrenia. So here's a bit of a Tom tip. When you're taking a history from someone who you suspect has atherosclerotic disease, somebody presenting with chest pain or intermittent claudication of their lower limbs, ask them about their exercise tolerance, diet, past medical history, family history, occupation, smoking, and really think about what are their modifiable and non-modifiable risk factors. This will score you really highly in exams and is useful when presenting to seniors or deciding what somebody's risk of having that condition actually is. So what are the end results of atherosclerosis? Well, this is really when somebody has established cardiovascular disease. So there's things like angina, myocardial infarction, transient ischemic attacks, strokes, peripheral vascular disease, and chronic mesenteric ischemia, when there's not enough blood flow to the bowel. So how do we prevent cardiovascular disease? Well, you can consider prevention of cardiovascular disease to fall into one of two main categories. Firstly, primary prevention, and that's trying to prevent cardiovascular disease in patients that have never had it, and secondary prevention, and this is when patients already have angina or they've had a heart attack or a TIA, and you're trying to prevent it from happening again. So the first thing is you want to optimize any modifiable risk factors. So you figure out what their modifiable risk factors are and then try to improve them. So you'd give them advice on diet, exercise, weight loss, smoking, alcohol, and treating any of their comorbidities, such as giving them really good control of their diabetes. Then you want to look at primary prevention of cardiovascular disease. And the way we do this in general practice is we perform something called a Q risk score, and at the moment we're on a Q risk 3 score. And this calculates the percentage risk that the patient will have a stroke or an MI in the next 10 years. If they have more than a 10% risk of developing a stroke or a heart attack over the next 10 years, i.e. their Q risk 3 score is above 10%, then NICE recommends that you should start a statin. So the current recommendation is for atorvastatin 20 mg at night. There's a slight exception in that all patients with chronic kidney disease or type 1 diabetes for more than 10 years should automatically be offered atorvastatin 20 mg once a day. The NICE guidelines actually recommend checking lipids 3 months after starting a statin and increasing the dose in order to aim for at least a 40% reduction in the non-HDL cholesterol. But I would always check adherence carefully before increasing the dose, because you might find out that the patient doesn't actually take their medication. Next, let's talk about secondary prevention of cardiovascular disease. And secondary prevention is after they've already had a heart attack, angina, a TIA, stroke, and so on. And the way to remember this is with the 4 A's. So the first A is aspirin, the second A is atorvastatin, and after somebody's had cardiovascular disease, we try and get to 80 milligrams of atorvastatin, compared to 20 in primary prevention. The third A is atenolol, or any other beta blocker. Usually we use bisoprolol, and you titrate that beta blocker to the maximum dose that they can tolerate. And the fourth A is an ACE inhibitor. Quite often we use something like ramipril. And again, we titrate this to the maximum dose that they can tolerate based on their blood pressure and their symptoms. Just a final word on the side effects of statins. There's 3 major side effects that it's worth knowing about. The first one is myopathy, and this is where the statins cause some kind of problem with the muscle fibers in the body. So the patient might complain of muscle pain or weakness, and it's worth checking something called a creatine kinase, which is a breakdown product from muscles, and this will tell you whether they're suffering with myopathy or not. The second is it can rarely cause type 2 diabetes or worse, glucose control. And the third thing is very, very rarely statins have been linked with hemorrhagic strokes. But usually the benefits of statins far outweigh the risks, and the newer statins, such as atorvastatin, are usually very well tolerated and have little side effects. So thanks for watching. I hope you found this video helpful.
This slide is showing you the differences. All heart diseases are cardiovascular diseases, but not all cardiovascular diseases are heart disease. Here's a visual about diabetes and cardiovascular disease. So now we're at the risk factors. Those are obesity, high blood lipid levels, high blood pressure, sedentary lifestyle, smoking, a family history, kidney disease, high levels of C-reactive protein. Why is kidney disease a risk factor? When the kidneys are not working well, your body has to work harder to regulate your blood pressure. And in turn, your heart has to pump harder, and that will lead to CVD. Patients with diabetes tend to have higher levels of CRP, an inflammatory marker associated with increased risk for cardiovascular inflammation and death.
This is John. John is 45 years old and has been living with type 2 diabetes for several years. And this is John's family: his wife Claire, his son Ben, and his daughter Lisa. John monitors his type 2 diabetes every day and lives life to the fullest. John feels in control of his diabetes and is confident that nothing serious can happen to him. One day, when John is enjoying the warm weather and good food in the garden with his family, he suddenly feels pain in his chest. John is having a heart attack. Luckily, his wife Claire reacts immediately, and an ambulance arrives quickly to rush John to the hospital. After a long and stressful night, John and his family receive the good news that he will make a full recovery. John's doctor tells him that his type 2 diabetes puts him at increased risk of cardiovascular diseases, such as heart attack or stroke, even at a young age, and that it is important to get screened for possible complications regularly. John is surprised. No one had ever told him that his type 2 diabetes puts his heart at risk, so he never had a reason to think that it could be important. If you have type 2 diabetes like John, you are at an increased risk of developing cardiovascular disease. Find out how much you know about diabetes and cardiovascular disease. Spread the word and join us in taking diabetes to heart.
John did not know that there was a link between diabetes and cardiovascular disease. It's our job to teach the patients. The signs and symptoms for CVD are subtle: shortness of breath with or without cough, extreme fatigue, and nausea and vomiting. These patients might have what is referred to as a cardiac cough or a heart cough. If it's dry, non-productive, it's probably a common side effect of an ACE inhibitor. With a wet cough with a frothy sputum that may be tinged pink with blood, it indicates pulmonary congestion. Nausea and vomiting is caused by a lack of blood flow to the digestive system from the CVD. CVD is going to cause lack of blood flow to all the other organs in the body. These patients may have a full feeling even hours after eating. First, we're going to screen for diabetes, and we do that with the fasting blood glucose and glycosylated hemoglobin. If the A1C is greater than 5.7, then it's in the diabetic range. Diabetic screening for CVD, we use lipid profile screening. You're going to check the high density lipoprotein levels and triglyceride levels.
So what does hemoglobin A1C tell us? Hemoglobin A1C, glycosylated hemoglobin, measures what percentage of hemoglobin proteins in your blood are coated in sugar. Hemoglobin A1C reflects average blood sugar levels for the past 2 to 3 months. This can be used to tell us how well a patient with diabetes is managing their glucose. Hemoglobin transports oxygen. Glucose sticks to hemoglobin on the way. Once hemoglobin is glycated, it cannot be undone. Glycated hemoglobin leads to impaired blood flow. So if we look at this diagram, it shows you a healthy red blood cell. It has some glucose stuck to them. You can see the glucose, the hemoglobin. And then if you look at the other one, it is a high A1C. That means an unhealthy amount of glucose are stuck to the cell. And you can also see that there. Glucose in the blood sticks to hemoglobin similar to donuts or hard gum. This reaction is called glycation. Blood sugar levels in glycated hemoglobin is comparable to speed and total kilometers traveled respectively in a speedometer. So here's just a visual of that. How do we screen for CVD in patients with diabetes? Lipid profile screening is recommended at first diagnosis, low-density lipoprotein cholesterol, and low-density lipoprotein should remain below 100 milligrams per deciliter. In patients with diabetes mellitus who do not have CVD, and below 70 milligrams per deciliter in patients with indications of CVD. Some interventions that we want to provide for our patients with diabetes would be to quit smoking. That's one of the big modifiable risk factors there. Staying active, so exercise doesn't have to be boring. Make it fun. An example is when I exercise, I usually listen to my music. It kind of keeps my mind off the fact that I'm actually exercising and makes it a little bit more entertaining. Diet, make sure that we're eating a good, hard, healthy diet. Maintain blood glucose levels. Control blood pressure. That's definitely a big one. We want blood pressure to be below 140/90 with a target of 130/80. Adherence to medications, aspirin, and lipid lowering recommendations. So patients with indications of CVD should aim for a low density lipoprotein level of less than 70 milligrams per deciliter. So in the slide before, I mentioned that diet is a modifiable risk factor for diabetes. So some of the things that they can do is reduce the intake of saturated fats. The majority of saturated fats come from meat and dairy products. Some examples of that would be pork, poultry with skin, tallow, lard, cream, butter, cheese, things like that. We also want to reduce our intake of trans fat. Trans fat is hard for our bodies to metabolize. And of course, cholesterol, reduce the intake of that. Some of the things we can increase to help that diet are omega-3 fatty acids. And some examples of that would be fish, nuts, seeds, plant oils. Fiber, want to intake some fibrous foods. Avocado, broccoli, dried fruit are just some examples of that. And then plant sterols. So plant sterols are found naturally in fruit and vegetables. They are naturally occurring compounds similar to cholesterol. When you eat them, they limit the amount of cholesterol your body can absorb. And some examples of that are legumes, vegetable oils, nuts, cereal, and seeds. Next, we're going to jump into some NCLEX style questions and see if we can answer those correctly. A client with MI suddenly becomes tachycardic, shows signs of air hunger, and begins coughing frothy pink tinged sputum. Which finding would the nurse anticipate when auscultating the client's breath sounds? A. A stridor. B. Crackles. C. Scattered bronchi. D. Diminished breath sounds. And the answer to that one is B. Crackles. Description would be a fine hair moving through fingers, coarse Velcro. That's just kind of a description on what you would be looking for that. It's due to collapsed small airways and alveoli. The location is in the lower lobes. An example is pulmonary edema. So pulmonary edema is characterized by extreme breathlessness, dyspnea, air hunger, and the production of frothy pink tinged sputum. Auscultation of the lungs reveals crackles. Bronchi and diminished breath sounds are not associated with pulmonary edema. Stridor is a crowing sound associated with laryngospasm or edema of the upper airway. And it has these other sounds that may be heard in their description along with it in this picture here.